Good afternoon, everyone, and welcome. It's wonderful to see you all here. I hope everyone had a chance to grab. I can only vouch for the chocolate chip cookies. I did not have a brownie or strawberry, but I assume they are just as delicious. So welcome. My name is Eileen Cantelme, and on behalf of the France Foundation, I'm so happy to welcome you here to our lunchtime symposium, Advancements in Pediatric ITP, What You Need to Know. So as we move into this program, our passion is to help you do your job and support the patients and families that you care for. And in order to do that, our objectives for you today, we are here to improve your abilities to stratify patients with pediatric ITP in order to select that appropriate first-line and second-line therapies, to monitor disease progression and manage chronic complications effectively, and also to really look at the new and investigational therapies and their role and potential role in your patients. So this is an accredited CME activity, so I have a few things that you might find on your chair. Some chairs, if you would like to do a paper evaluation for CME credit, we are happy to process that for you. We also have a postcard, 2 different QR codes. On one side is the QR code for our CME evaluation and credit claiming for after the activity. And the other side has a QR code to our audience response system where you'll be answering questions throughout the presentation. And also you can ask your questions via this slide, via this QR code. We also have Q&A cards. If you would rather write your question down, find a staff person, we'll bring it up to faculty. Okay, so a bunch of different ways to engage in our program today. Our disclosure information for our faculty, who I'll introduce in a moment, and I want to take a special moment to recognize the Independent Medical Education Grant from Sobi that supported this education. All right, so we're going to move into our first, this is a test, though I don't think anyone can fail this one. Well, maybe. So if you get out your phone and point it at the QR code, it's going to launch the audience response that will be used for the rest of the presentation. Here's our practice question. Okay. Oh, we've got Batman. Batman's front runner. Okay, Mickey Mouse. We didn't know with the pediatric, audience if you all might get this. I'm gonna let you know, Michelle. You knew this. Darth Vader. Darth Vader is actually correct. Yes. Who knew? Now we know. All right. A little bit of trivia. So great to see people participating. Every time a question comes up throughout this presentation, that same QR code will come up. So if you've already engaged in that, just go onto your phone to answer questions. And if you want to start weighing in, you can scan the QR code and move on from there. All right. I believe that is what we have to share with you before I turn it over to our faculty. So I'm very, very pleased to introduce our faculty, Cindy Neunert, Michelle Lambert, and Joel Livingston. And I'm going to turn it over to them, but if you need anything, please find any of the staff here, and thank you for coming.
Thank you, and thanks everyone for coming to the session today on pediatric immune ITP, really a topic that's near and dear to my heart and started in fellowship and has become my hematology focus as a staff. We're going to start a little bit about what is pediatric ITP, and I'll give a brief background on some of the things we do know about ITP, and then we'll lead into a patient case that will help guide our discussions on management. So initially, pediatric ITP is an acquired immune disorder affecting the platelets. And in children, we most commonly think this is triggered by a viral infection, a cold or a flu, that then leads to antibody production targeting the platelets, increasing platelet destruction, and also impacts on the megakaryocyte, which may impact decreased platelet production. ITP is a clinical diagnosis, and it's a diagnosis of exclusion. And in children, we can often make this in the absence of symptoms that would point to an alternate diagnosis, and specifically the absence of red flags on history, on physical, and in lab investigations. Some of the keys that we do need to do to make this diagnosis properly is a CBC with differential, important to assess if there are other cell lines affected, and a presence of other cells such as blasts. And that will require an expert review of the peripheral blood smear. In cases where there's diagnostic uncertainty, sometimes we should use some ancillary testing, and those investigations are listed there, things like immature platelet fraction, and in rare cases, bone marrow examination if there is diagnostic uncertainty. We are learning more every day about the causes of pediatric ITP and ITP in general. And there's a mix of an autoimmune trigger, potentially with viral infections. It's been shown with other non-viral triggers, COVID vaccine, COVID itself. And then there's also a likelihood of a genetic predisposition. And what we don't understand is why some people get ITP and why some people don't. We're very familiar with common pediatric ITP symptoms. You can see here are some skin changes such as bruising and petechiae. And then there's most commonly mucosal bleeding, so epistaxis, blood in the urine or stool. Heavy menses is also quite common in adolescents. And we're most concerned about obviously bleeding intracranially, but that thankfully is very rare. What is less commonly thought of when we think about ITP and symptomatology is the impact on mood, such as feeling tired, fatigue being a common factor, and then often for patients that develop chronic ITP, frustration with having a chronic health condition. It's important to look at that and the impact of ITP on the patient and also on the family and how it's impacting quality of life when we think about treatment. Let's get to our patient case. So Cassandra, in this picture here, is a 9-year-old newly diagnosed with ITP. She's been referred to your pediatric hematology clinic from a pediatrician for further evaluation and management. This time she's presented with mild bruising. She has a few petechiae, but no mucosal bleeding or other symptoms. And when you do a CBC, her platelet count is 22, and otherwise the CBC is normal. She's treatment naive. So getting to our next polling question, testing what you know. So in this 9-year-old who presents with mild bruising and petechiae, but no other bleeding or symptoms, and a platelet count of 22, which would be the most effective next step in managing this patient? Administer a platelet transfusion, start daily corticosteroids, observe and monitor, or begin rituximab. And just clarifying, are the responses going to pop up, or are we doing a count? Oh, I have to click it. I apologize. There we go. Maybe I wasn't giving everybody a live answer. So you had to make the choice before understanding what other people are choosing. And so 85% have chosen observe and monitor. 12% start corticosteroids, administer platelet transfusion at 1%, and begin rituximab at 1%. We'll get to the answers at the end of the talk. So let's talk about indication for treatment in ITP. So in asymptomatic patients, treatment may not be indicated, and observation may be the most appropriate management step. But sometimes treatment may be indicated in patients with bleeding because there's another risk. For example, platelet dysfunction, if there's another hemostatic defect, there's recent trauma or recent surgery, or clear comorbidities for bleeding or lifestyle. So, a rambunctious toddler that has older siblings knocking them around may be influencing your decision to treat versus a child who is, very quiet and enjoys reading books. Overall, our goals for treatment are ultimately to prevent serious hemorrhagic complications, and sometimes the goal is to double your platelet count baseline and at least achieve a platelet count of 30 to 50. Prevention of subsequent hemorrhage is also a target, and overall we want to balance some of the side effects of our therapies. So we want to improve health-related quality of life and not make it worse by adding unnecessary treatments or treatments that have a lot of side effects. It's important for us to provide a treatment-free response and remission, and that's the ultimate goal, but our primary goal is to prevent serious bleeding. Another polling questions. What barriers do you currently face when you discuss treatment options with your pediatric patients and their caregivers? I'll open this one. Now I can open. No? It is open. Okay. There's some good answers coming in, I'll say, and very common things that I can see coming up about family and patient fears, anxieties, costs, very recurrent themes. That's great. Yeah, and really important thinking about, the things that have come up. Bleeding is a high thing, costs of treatments, and concerns with treatment and outcome. I'll move on now. Thank you. So important to stratify who may benefit most from treatment and who may not require treatment. And there's a few things that would be important to consider. One is the overall bleeding risk. So, obviously if a patient is presenting with life-threatening bleeding, the indication to treat is there, and it's more of a choice of which agent. And then if the second question is about those that are going to develop chronic or long-term ITP, what are the best options for maintaining lifestyle? And it's important to balance the efficacy of treatment and the impact of side effects. We know a little bit about those that may be more at risk for developing long-term ITP. There's been some biomarkers of prognosis, but it's not a perfect science. So some children will develop ITP, some children will develop chronic ITP, and we're not really that good at developing a model for prediction, although we've tried. Bleeding, I think we've done a better job at, and so deciding what is no or minor bleeding has been better defined in this scale, and those may be the most appropriate for observation and continued active outpatient monitoring. When you get into more serious, mild and moderate bleeding, that's when you start to think about the role for therapy. And obviously severe or life-threatening bleeding is something that you want to treat and treat quickly. Some groups have worked on developing ITP recovery scores or predictions for who's going to develop chronic ITP. This tool is maybe not the most clinically relevant, but a few concepts are important, such as age. We know that teenagers may be more likely to develop chronic ITP, as well as the females being more likely than males, for example. This is our overview of management options. So initially, first-line therapies, observation, as we just mentioned, for patients who have no or minor bleeding. Treatments including corticosteroids, intravenous immunoglobulin, and anti-D. Second-line therapies include TPO-RAs, or thrombopoietin receptor agonists, rituximab, splenectomy, and then immune modulators like MMF, as well as fosmanidinib in adults. There's also some subsequent therapies that have less evidence, and those will be discussed a little later. So back to our patient case. Cassandra, if you remember, has come back to your clinic a few months later after her mom noticed some more significant bleeding, including frequent nosebleeds. She has blood crusting in her nares, she has over 150 petechiae on her body, and she has 2 large ecchymoses on her body. Her platelet count is very similar at 17. At this point, given she's progressed in terms of symptoms, a short course of corticosteroids is prescribed. Let's talk about these first-line treatment options, including observation corticosteroids and IVIG. The ASH 2019 guidelines on ITP have discussed in children with newly diagnosed ITP and no or minor bleeding, the recommendation is observation over corticosteroids and observation over immunoglobulin and anti-D therapy. So in summary, not to treat. In the event that you do need to treat, let's talk about some of the options. So corticosteroids, we know that these can be delivered oral medications as an outpatient, which is one of the benefits, and they result in a rapid rise in platelet count, and they're relatively low cost and familiar to patients and families. Some of the risks are acute toxicities such as insomnia, irritability, increase in change in mood. And then long term, we know that if you're on prolonged courses of steroids, you may have multiple toxicities related to more Cushingoid. So in general, a good outpatient option, but best to use in limited periods. Monitoring, we usually expect a platelet count rise over the first few days with an expected CBC rise in 3 to 7 days. Important to look at side effects such as mood changes, sleep disturbances in assessing the need for future therapy. And it's best to do as short as course as possible. In my practice, I use 4-day courses of steroids rather than extended courses. IVIG is limited to be given in a hospital setting and does carry some benefits in that it may raise the platelet count slightly faster than steroids, but it also carries additional risks. So infusion reactions being quite common, hemolysis, as well as aseptic meningitis, which may cause a severe headache and necessitate further imaging. Monitoring is done in hospital while the infusion is given, and you may see a platelet response a little faster, so checking after 24 to 48 hours. And this is more useful when there's more significant bleeding or more need for an urgent rise in platelet count because of bleeding symptoms. So back to our case, and this is where I'll hand it over to Dr. Neunert. This patient has not succeeded.
So we're going to come back to Cassandra now, and we did give her corticosteroids, and she had some acute symptom relief, but according to her parents, had some of the usual side effects. She had behavioral changes, had some insomnia, and she's now in your clinic a week later and only has minor improvement in her platelet count and clinical symptoms. So our question becomes, which of the following is a preferred second-line treatment option for pediatric patients unresponsive to first-line treatment according to the ASH guidelines? Aspirin, splenectomy, anti-D immunoglobulin, or thrombopoietin receptor agonists, the TPORAs? I feel like we need some good Jeopardy music. This is our active poll. Everybody, please get your phones back out. See some results come in. Okay, so 86% went with a TPORA, 14% anti-D immunoglobulin, 0% aspirin, and 0% splenectomy. So again, we'll loop back to these at the end. So when we talk about second-line therapies in children with ITP who are unresponsive to our first-line therapies, the ASH guidelines, the panel suggested TPORAs rather than rituximab and rather than splenectomy, and rituximab rather than splenectomy. So basically in a ranking system, the TPORAs were preferred, followed by rituximab, followed by splenectomy. These were all conditional recommendations based on very low confidence in the in the evidence, because we really have no randomized trials putting these things side by side. But it was felt that the risk of TPORAs is thought to be low and potential benefits high compared to rituximab and splenectomy. The risk of rituximab was thought to be less than that of splenectomy, but there was a desire to avoid immunosuppression overall in this population, and then also recognizing the need for long-term management strategies post-splenectomy as well, and appropriate immunizations. And there really was a push both in the ASH guidelines and in the international consensus document to avoid splenectomy until at least a year of disease. This did include a good practice statement, though, and this is where I think we really get to focus on the art of medicine. And this is that it really should be an individualized approach. It should be based on the context of the ITP, the duration, the frequency of the bleeding symptoms, the need for rescue medications, comorbidities, social factors that might influence which treatment is best for a particular patient, and then really a discussion about patients' values and preferences and availability of these medications. And this is where we can engage our patients in education and shared decision-making, which is highly encouraged in this setting. And then lastly, again, the good practice statement of really trying to delay splenectomy. So we've talked a little bit about some of the more general first-line therapies. And so now we're going to focus on splenectomy, rituximab, and our TPORAs, which are more in our second-line therapy categories. This comes from the adult side of the ASH guidelines, but I do think it is helpful in thinking through when we have two things, we have no evidence, we don't have randomized trials, what are the types of questions and things we can think about? And here for an adult patient, they're putting values and preferences around goals such as remission or being off medication, lifestyle, things that might influence whether or not we would go with a medication like rituximab, which is a short few infusions, versus a more ongoing therapy like a TPORA. So you can see how these two things, while vastly different, might actually apply to patients differently based on patient goals. So the TPORAs do have some benefits. In the majority of patients, they'll provide a durable platelet response. They've been shown to reduce bleeding events. They lead to an overall improved quality of life so long as they're addressing the goals that we set up front. And they are suitable for long-term management. We're having more and more pediatric patients on these drugs for quite some time. In principle, they work just by going to the megakaryocytes and increasing, as we just had a nice plenary session on TPOs. They go to the bone marrow, they really stimulate that platelet production. There are some potential risks. With L-thrombopag, we do have to monitor for liver enzymes. They do require more monitoring. So for a patient that isn't coming to clinic that frequently for lab draws, it's important to let them know that they may require more monitoring of their platelet count than they're currently getting. There is possible rebound thrombocytopenia. So when these drugs stop, some patients do go below their baseline and have bleeding that's more severe than what they've had before as well. L-thrombopag has a dietary interaction. And then there's low risk for bone marrow reticulin, which we've seen in adult studies where they actually did bone marrow biopsies on patients receiving TPORAs. And so that's not really a concern. And in most of those patients, there was some other change or indication on the CBC that a bone marrow was needed. So it's not recommended to do a bone marrow before starting, and they're only needed for surveillance if there's some other change in the CBC. We do have to monitor. So again, we talked about maybe there's a side effect of increased visits and laboratory testing, because platelet counts really should be checked weekly during initiation, and then we can move to more of a monthly once we know what their kind of steady state dose is. The liver function testings we talked about with L-thrombopag. There's a slight risk for thrombosis. We do education on this. I think there's still a little bit of debate as to whether or not this is drug-related in essence or some other characteristics of the patients themselves. L-thrombopag at one point had cataract monitoring requirements. This is not necessarily any longer and seems to be mostly in patients that are also receiving corticosteroids. And I think we have to be aware L-thrombopag is an iron chelator as well, so patients have developed iron deficiency while on this, even in the absence of bleeding symptoms, so something else that is important to periodically screen for and check. For all of these, I think another nice thing though is that we can kind of dose adjust them to fit a platelet count that meets our goals. There are titrations for each of these different drugs based on maintaining a platelet count between 50,000 and 150,000. But really, in essence, we can kind of achieve a target that lets us get the patient to do the things they want to do. And I think that is a nice way to use these drugs in some circumstances. And so I really, in my clinical practice, will taper to the lowest effective dose that gets the family to where they need to be in living with ITP. And I don't really feel as though I need to push for more drug just to achieve a normal platelet count per se. And again, there is this loss of response after stopping the therapy, although we are learning from some adult data that there is some patients that go into a sustained response off treatment, but I think we have to still have some data to further come on that. This is just a study I want to highlight. There is an ASH abstract from this year from just the most recent ASH meeting that people can reference, and hopefully the manuscript coming out soon. But this is the PINE study. This is pediatric ITP, newly diagnosed patients that received either L-thrombopag or standard of care therapy. It was for pediatric patients 1 to 18 years of age with ITP for less than 3 months. They could be either treatment naive and or have failed a first-line therapy and were needing to go on to subsequent therapy. And we randomized them 2 to 1. And the primary endpoint was greater than 3 of 4 weeks with a platelet count greater than 50,000 during weeks 6 to 12 without use of rescue therapy. And you can see here in this last box that 65% of the L-thrombopag arm and only 33% of the standard of care arm achieved that goal. And the study was actually closed early due to meeting the efficacy endpoint. And so I think how we utilize these second-line therapies, I think is going to evolve. I don't think we necessarily have to think of them as patients who have had ITP for 6 months and meet some certain definition of persistent ITP. I think that they are readily available to use when a patient needs them. And we shouldn't be bound by terminology or the confines of waiting for a certain time point. I think if they're available and you have a patient that would benefit, we should consider using them. Rituximab is a monoclonal CD20 antibody that most of you are familiar with. This works by directly depleting our B cells that are making our antibodies. And it does lead to a long-term remission in some patients. Upfront response rates are roughly 60%, 70%. And then by 5 years, we really see that kind of taper off, and there's suggestion of only about 20% of patients remaining in remission at 5 years. But it is a good option if a patient really desires a therapy that might provide them with some degree of remission and or a time of living with ITP and being off of therapy. There are risks, though. We have to make sure that we've done immunizations up front. There's viral reactivation that can be seen. A lot of patients do experience an infusion reaction, and it's not appropriate for acute bleeding, so it does take time to work. Although if you have a patient with severe bleeding and you really think you need to give them everything, I wouldn't withhold rituximab, but you have to do it in the context of other emergent therapies. The thing that we also worry about in pediatrics is we have seen reports of persistent hypogammaglobulinemia following use with rituximab, where the normal immunoglobulin population does not come back, and so we need to monitor that closely. It does seem to be more common in patients with a baseline immunophenotype. So we're monitoring, again, we need to watch during the infusion for infusion reactions. We check our T and B cell subsets to look for depletion as well as reconstitution, as well as immunoglobulins to check periodically. And then our response time can be weeks to months, as I mentioned, so not appropriate for use as an acute agent. And the management, we really do our 4 doses. This is the standard treatment, is 4 doses weekly, and then we wait. There's some adult studies looking at how many or how often can we repeat doses, a single dose of rituximab going forward if somebody loses their response. But I think we really don't have a long-term dosing strategy yet available. And now splenectomy. This is our historical therapy. This at one point was really all we had. And it really does simply work by removing the site of the macrophages where the platelets are undergoing phagocytosis. So we still have antibodies, we still have antibody-coated platelets, they're just not being removed from circulation. It does lead to long-term remission in the majority of patients without the need for ongoing therapy. And so it is nice in that setting. It is sort of a procedure, it's done, the majority of patients will respond. However, we have to balance this against the risks of surgical complications, the long-term risks. And I always say when we're dealing with pediatric patients, a long-term risk is a really long time. So long-term increased risks of infections, this increased risk of thrombosis that we see also with splenectomy, decreased vaccine responsiveness. So again, we want to make sure we get our patients vaccinated before splenectomy. And oftentimes when we're choosing splenectomy, it's in an emergency setting where we may not have that ability. And we have to then provide education. We've now taken away their ITP, but given them another condition in which they need to seek medical treatment for fevers anytime. And so really our management and monitoring is really to educate the patient. We will monitor platelet counts frequently, and we have to make them aware of these lifelong risks and ensure that they have their appropriate immunizations and antibiotic therapies when needed. So now we're going to pass Cassandra off to Dr. Lambert. She didn't like my care, and she's seeking a second opinion.
Never. All right. So Cassandra comes back a year later. She's doing pretty well on the TPO receptor agonist that she's been on, but her family wants to know how long does she need to be on this treatment, and is interested in learning about any potential new therapies or alternatives that might be available. So, was that one or two? There we go. All right, so we'll do another poll and see what do people think about how treatment with some of the newer agents might impact a patient's quality of life. And it's a little unfair because we haven't even told you what they are yet, but let's see what people say. Nope. Nobody's answered yet. Yeah. Costs. Changes in quality of life. Maybe something without the dietary restrictions or need for weekly injections. Traveling if you're on a clinical trial, great. All right. Cost is coming up a lot. All right. So we'll talk a little bit about some of these emerging therapies that are under investigation, in particular in pediatric populations, and we can touch a little bit about some of the other drugs that have been developed or in development that are not yet coming to pediatrics, but in particular, like fostamatinib, a spleen tyrosine kinase inhibitor. It's been examined, it's been used, there are 2 case reports published, or case studies published for the use of fostamatinib in adolescent patients, but there's no ongoing clinical trial in pediatrics. But we could talk about avatrombopag, rilzabrutinib, hitrombopag, which is another TPO-RA, daratumumab, and obinutuzumab. And it takes a little bit of practice to say all those names, but hey, those who do oncology are used to this. All right, so what's the relative incidence of grade 2 bleeding events reported in clinical trials assessing safety and efficacy of AVA compared to placebo? I'm curious to know if people know. Cool. So I'm not going to give the answer yet. We'll talk about it, and then we'll see what people learn or don't learn. Okay. So avatrombopag has actually completed a phase 3b multicenter randomized double-blind placebo-controlled parallel group trial, and it was for pediatric patients who had ITP for greater than or equal to 6 months. They were randomly assigned 3-to-1 to receive AVA or placebo for 12 weeks and stratified by age group. The study looked at both safety and efficacy, and serious events occurred in about 9% of treated patients, with 4% of patients in the avatrombopag arm withdrawing due to leukocytosis or vomiting, and grade 2 bleeding events occurring in 19% of avatrombopag patients and 38% of placebo patients, so about a 50% reduction. As far as efficacy goes, 92% of patients that were treated in the avatrombopag arm achieved a complete molecular response, or a complete response. I don't know what's CMR. And only 19% of placebo patients. But important to note that 19% of placebo patients had what was considered a complete response, because that's our spontaneous remission rate, and that's why it's really important, at least in pediatric trials, that we at least think about either a placebo arm or a historical control arm, so that we can really understand how the response rate differs from what the spontaneous remission rate is. And then 48 or 89% of patients received or achieved a response at any point in time, and only 10% achieved a response. The mean percentage of time was about 60% of the time for avatrombopag patients and about 16% of the time for patients on the placebo arm. And so it's important to note that those patients who did achieve a response actually maintained that response for longer than those patients who were in the placebo arm. And there's a PDUFA date that's already been scheduled for July for the FDA to review avatrombopag pediatric data, assuming the FDA meets. So another TPO receptor agonist that's also in clinical trials in pediatric patients is hetrombopag, and this is actually being studied outside of the United States, North America, and Europe. It's being studied primarily in Southeast Asia. It's a phase 3, 2-part double-blind randomized placebo-controlled trial. It was expected to complete enrollment in December, and the primary outcomes for this trial will be proportion of patients with a platelet count over 50 at week 10, and then peak platelet counts from baseline at week 2. So, and in a phase 1 study, the median time to first response was about 2 weeks, and the median duration was about 3 weeks. So, and also showed a decrease in bleeding compared to baseline. So we'll see what hetrombopag ends up showing us. So next is rilzabrutinib, and rilzabrutinib is a BTK inhibitor, or a Bruton's tyrosine kinase inhibitor. It has multiple postulated mechanisms of action in ITP, and the reason that we're not entirely sure exactly what it's doing is because it can affect multiple different immune cells, and the time to response was surprisingly fast for a drug that was initially postulated to reduce antibody production. In the adult trials, patients responded within about 2 weeks. Within about 2 weeks, and that's way too fast if you're just decreasing antibody production, right? Rituximab takes 4 weeks or so in most patients to see a response, and so 2 weeks was too fast. So it seems like it also inhibits macrophage and monocyte IgG-mediated FcR gamma activation and phagocytosis. And it also probably decreases some of the inflammatory mediators that play a role in ITP. So the adult trial has been completed, and the pediatric trial for rilzabrutinib has completed enrollment. So we'll see what the final data show. This is also a phase 3 multicenter double-blind placebo-controlled trial, and it studied adolescent patients down to 12 years of age, actually. Patients were randomly assigned 2-to-1 to receive rilzabrutinib or standard of therapy, and that included potentially TPO-RA. You just need to be on a stable dose for the 24 weeks. And patients were stratified by splenectomy status, and the most common adverse events that were described were like abdominal stuff, diarrhea, nausea, and abdominal pain, headache, and most of these were grade 1 to 2. There was one SAE on the adult side of a grade 3 peripheral thrombosis. pulmonary embolism. In adults, there's 23% response rate. We don't yet know what the pediatric trial is going to show us, but it does seem like the adult response rate to rilzabrutinib is improved, and this was in heavily pretreated patients. So the next class of medications that's being studied, and there's actually a pediatric trial that's opening. I don't think that they have enrolled any pediatric patients yet, but looking at anti-CD38 antibodies. So anti-CD38 antibodies mediate not just B cells, but also affect B cells, T cells, and plasma cells. So the idea here is to get those patients who have not responded to an anti-CD20 antibody, for example, or something like that, to get the plasma cells as well. There was one study that sort of looked at off-the-shelf daratumumab for ITP in adults and pediatric patients. This was a sample size of convenience, and 4 out of the 7 patients achieved a complete response in that sort of case series. There is a phase 2 prospective one-arm open clinical study, and that will enroll patients that are greater than or equal to 6 years old with ITP for at least 3 months. So we'll see what that ends up showing us, with the primary outcome of 2 consecutive platelet counts of over 50 within the 8 weeks of treatment. And this is both a safety and efficacy study. All right. So we have rituximab as an anti-CD20 antibody, but rituximab's penetration to tissue and the biosimilars to rituximab is not as good as some of the newer anti-CD20 antibodies. So obinutuzumab is an anti-CD20 antibody that has better tissue penetration. And so in theory, you could get those B cells that are actually still hanging out in different tissues rather than only those that are circulating. It has been looked at in adults, and the phase 2 study is going to include pediatric patients down to 12 years of age. So in the adult data, there's some preliminary data that's available showing sustained responses in patients who had relapsed or refractory ITP with 3 complete responses and 2 partial responses. Infusion reactions are pretty common in obinutuzumab, sort of like rituximab, especially with the first dose. And so those were manageable. And then there were 3 infections in the 9-month follow-up period post-obinutuzumab infusion. So we'll see what that looks like for at least our adolescent patient population. So the difficulty in managing pediatric ITP that becomes chronic and has, and you've decided with the family in your shared decision-making that you are, for one reason or another, no longer willing to just observe, or you have bleeding symptoms or something, we really don't have a lot of efficacy data, especially for some of these novel therapies that are starting to be used more in adults. So I think we need better assessments. We need better assessments of quality of life. We need some biomarkers. It would be really, really nice if I could see a patient on that first visit and say, okay, well, your ITP is going to respond to this treatment. And so when we pull the trigger on treatment, this is what we should do. It is really important still to assess the patient values and preferences and to continue to assess those questions. So if a family comes to me and they're like, yeah, we're fine on L-trombopag, but what else is there? Then we start to talk about, okay, well, why are you asking? What are you looking for that you're not currently getting? So it's a lot of conversation. And I think there are a lot of patient factors and external factors that can help influence or that may influence what we end up choosing as our therapies, patient characteristics and other medications and preferences, whether or not they've had prior experience with that medication, and whether it was tolerated before. And then unfortunately, in the day that we live, there are both regulatory and financial restrictions on some of the drugs that we can use. Particularly, I know in like Canada, and in other countries, some of these drugs are just not available, whereas sometimes in the US, since avatrombopag and the new, more generic version of eltrombopag are cheaper than Promacta is, some of our insurance companies at least have been telling us to switch patients, even though there's no pediatric data for Alvyas and the avatrombopag has not been approved yet. And so I think it's one of those things that sometimes force our hand and tell us what we have to do. Clinical factors, of course, response tolerance and the schedule of the drug. Some of my patients choose romiplastim because it's once a week, or they choose a TPO because they just want to take one medicine once a day. And then, of course, we worry about risk of bleeding, exactly what the platelet count is, because maybe those patients who have the lowest platelet counts are a little bit more refractory if they have unmeasurable counts. And so we really do need to, I'll just argue again for this shared decision-making model, because ITP treatment is complex, and we really need our patients to be engaged in that decision-making. Am I doing this one, or are you? Okay. So personalized treatment based on bleeding risk, likelihood of chronic disease, not that we can really predict that, but and patient family preferences. TPO-RAs do offer durable steroid-sparing options. They're used earlier and earlier in the treatment pipeline, and we have some additional TPO-RAs that are coming down the line that may be even easier to use than the ones that we're currently using. Monitoring strategies should look at not only the platelet count, but also bleeding symptoms, side effects, health-related quality of life, and whether or not your patient is happy and satisfied with the response that they're getting to the medication, regardless of what the platelet count might be doing. And it's really important to continue that shared decision-making. All right. Now it's you.
So after seeing Dr. Lambert, Cassandra and her family came back to me. They felt reassured about staying on the TPO-RA while awaiting all of these novel new things that are in the pipeline to make life better and easier for our patients. So let's loop back now. Now we're going to actually give away the answers to our questions. So our 9-year-old girl with ITP presents with mild bruising and petechiae, no mucosal bleeding or other symptoms. Platelet count is 22,000. Which of the following is an appropriate next step in management? Administer a platelet transfusion, start daily corticosteroids, observe and monitor, or begin rituximab? All right, so 100% correct. It is more than appropriate to observe a patient like this. Again, this is balancing risks with benefits of therapy, and our ASH guidelines would support observation for a patient such as this. So which of the following is a preferred second-line treatment for pediatric patients unresponsive to first-line treatment according to our ASH guidelines? Aspirin, splenectomy, anti-D immunoglobulin, or thrombopoietin receptor agonists?
Somebody's being silly.
All of a sudden, we have a vote for aspirin that we didn't have before. Poor Cassandra. We're almost at 100% for the right answer. So thrombopoietin receptor agonist is the correct answer. Again, there was a little bit more of a tiered approach with second-line therapy for children compared to adults, where we valued TPO-RAs because they were immunosuppressant-sparing options, followed by rituximab, and then lastly, splenectomy. Okay, so what was the relative incidence of grade 2 bleeding events reported in clinical trials assessing the safety and efficacy of avatrombopag compared to placebo? Higher incidence in AVA, Avatrombopag had no incidence of bleeding, while placebo had a high. Incidence was half as high in avatrombopag as compared to placebo, or the incidence was similar between the two. So pretty much almost a majority. So incidence was half as high in avatrombopag as compared to placebo. It was about 20% in the avatrombopag group and about 40% in the placebo group. So I do think that if we look not only at the surrogate of a platelet count response, we do see that these medications also get us clinical outcomes that are meaningful in terms of reduction in bleeding, reduction in other concomitant medications, and less need for rescue therapies. So we talked about Cassandra. She's doing well. The family continues to be happy, but we do have hope and promise for what is on the horizon. So now we're going to move to our questions. We've already had quite a few questions come in. So keep submitting them by the poll, or you can come up to the microphone if you want. We're very friendly. Or if you want to remain anonymous, you can also use the piece of paper on your seat. So are there any specific efficacy differences among the currently available approved TPO receptor agonists? At the moment, there really are not. The main difference is in the monitoring strategy and the route of administration. In terms of, again, we talked about L-thrombopag being specific with dietary, liver, and iron chelation. Ramipelstim has the once-a-week injection, which some families really are averse to, although I've often found that a weekly injection is easier for some families. So I really think it comes down to which therapy fits best with a family's lifestyle. I think the other thing to note in this discussion, though, is that if a patient fails one therapy, you can try them on a different therapy. So the TPORAs all do act on different sites of the receptor. So just because a patient fails one does not mean that they may not respond to another, and it's worth trying alternatives. How do you determine whether children can go to daycare or participate in sports? Dr. Lambert, how do you address sports participation?
For what are considered, the hemophilia rated low-risk sports, I have no platelet count minimum. I let them participate. So dancing, golf, those sorts of things. In sort of the more moderate risk sports, it's a conversation with the family, and we talk about risk-benefit of participation. And I will admit that I have started patients on therapy in order to let them play football. American football, as much as I personally don't. I prefer brains to football, but I do think that for some families, it's just such an important part of who that patient is that I do everything I can to facilitate participation when it's something that's really important to them. As far as daycare goes, I let kids go back to daycare. I don't have a minimum platelet count for daycare. I think if you don't trust your daycare providers with a platelet count that's low, then maybe there's some other trust issues that are happening there, and I think it might be time to think about whether that's the right option, but if they're really watching the children, they'll be fine.
So I think that the statement in green there should not have a question mark at the end, but should have an exclamation point. Do not wait 6 months to start TPO treatment. If you have a patient that needs a TPO-RA and that therapy seems to fit best with what's going on with that patient at that time, I think that it is very appropriate therapy. Our labeling indications, don't forget, are based on what was done in the clinical trials. It is our job to provide real-world data and or additional clinical trials to show alternative use and thought process on what is actually best for patients. So now we'll switch gears, come over to the microphone.
Thanks so much for the presentations and all the excellent knowledge. I'm Nessra, and I'm from McMaster University in Hamilton, Ontario. My question is in regards to bone marrow fibrosis in the context of TPO-RAs. I have a patient who's been refractory to everything, inclusive of avatrombopag. And I recently did a marrow while she was on that, and it does show an M1, M2 marrow fibrosis. I'm wondering if you have seen this and what your approach might be, any advice you have.
So, the story of the marrow fibrosis is an interesting one because even inflammatory conditions, lupus patients, patients with other conditions, not ITP related and not on a TPORA, can get marrow fibrosis. So it can be relatively non-specific to a TPORA. And in the adult studies, most of the bone marrow reticulin they saw was of this level 1, level 2, and the problem is not knowing what they were before starting the TPO, because many ITP patients may even have some reticulin, and in that study, no one really showed advancement when they did the bone marrows pre, but I don't know if either of you have significant experience. I don't do a lot of marrows on patients, so it's rare for me to come across the reticulin problem unless somebody has really got some other indication that their marrow is under stress and I feel I need to do the bone marrow.
I usually will do a really thorough immune evaluation in that patient.
Yeah.
And I worry that it's an inflammatory ITP that they have, and there's something else that's driving inflammation that's causing that reticulin fibrosis. I will say that if you're using high doses of TPO receptor agonists, like super therapeutic doses, you can sometimes see increased reticulin fibrosis, and then you have to find an alternative therapy. I wouldn't leave the patient on, what are above the recommended doses for ITP for long term, especially if you're seeing reticulin fibrosis.
Thank you so much.
Hi, everyone. Great presentations. Thank you so much for your time. I'm Sashi Goteti. I'm a pediatric hematologist at Primary Children's in Utah. Given that ITP is such a dynamic and multifaceted disease, what are your thoughts and recommendations on using multimodal therapies? I have a handful of patients where I found combinations of TPO and MMF or sirolimus being very, very helpful. So I guess the second part of the question is, are there any efforts to standardize any of those in literature?
Excellent question, and thanks for adding to our to-do list. Dr. Livingston, any thoughts on combination therapy?
Yeah, that's a great question, Sashi. That's more the difficult to treat patients are the ones that we often spend 90% of our time thinking about what to do in these very rare patients. I find that the secondary ITP, particularly in teenagers with autoimmune conditions like lupus, the combination is somewhat effective. So for example, if they're diagnosed with lupus and they're started on MMF, I have done the combination with the TPORA, but outside of that, I'm a little bit looking to some more seasoned experts for some better guidance other than a trial and error approach. But I think it is worth to consider for therapeutic options for people that really don't have any other choices.
I do.
Yeah, I would echo that. I think it's
Not
worth,
steroids, if I can help it though.
yeah, avoid the steroids. It's worth trying, and it really is trial and error, which is the frustrating part.
Hi, thank you so much. And I'm Kisha, one of the pediatric hematologists from Oklahoma. And my question is regarding some of the immune dysregulation patients, like the DeGeorge patients that we know are, hard to treat. So in those patients, is your choice of agent different upfront? And second question is, when you, they're coming to your clinic and they have chronic refractory ITP, let's say, or just primary initial refractory patient, when and how do you start their workup or for immune dysregulation or secondary immune conditions? And what is the role of that in workup?
Yeah, so I think if you have a patient with ITP in the setting of a very specific targeted immune dysregulation or IEI, the drug of choice should target that pathway if available. So sometimes even a JAK-STAT or something else, a different approach in that patient is entirely reasonable to think about. And I know Dr. Lambert can comment on that as well. And I think those patients need better input from immunology colleagues and a true immune dysregulation team, and I treat them very differently than other standard ITP patients. In terms of the workup, this is something that we as a ICON group, all three of us are part of ICON, actually all agree we need to be more thoughtful in our standardization of who, when, and how to work these patients up. And we are working with NICER, which is an immunology group, to try to get some consensus on how to do this. Because I think it's highly variable, and we've done survey data that shows it's a highly variable at what stage and in whom. I think people are, because of some of the data coming out of France and other places, doing the workup much sooner.
Yeah, I mean, I do it when I see the patients, but that's usually because they come to me after they've already had a bunch of treatment or whatever. So, but and at a year for everyone.
Yeah.
At 12 months for anybody with ITP. If you still have ITP at 12 months, you deserve an immune workup if you're a pediatric patient. I think if you're an adult patient too, but that's my personal bias.
Immunologists are hard and difficult to find.
Yeah.
We have nobody in our state. So would you consider using rituximab earlier on in the treatment of these patients, or MMF or something like that?
So I'm a little hesitant to use rituximab in these patients, depending upon what fundamentally they end up having in terms of the IEI, but that was one of the markers for persistent hypogammaglobulinemia. Now, whether or not that is a patient that was going to develop that at some point anyway, as are we just uncovering a CVID that wasn't picked up before? But I think I always screen, in addition to kind of, as Dr. Lambert was saying, routine screening in certain time points, I also will routinely screen somebody prior to giving them rituximab. I think that's a really important piece to make sure that I'm not going to do more harm in that patient by exposing them to rituximab.
Although if they're already hypogam,
Exactly.
when you're thinking about rituximab, you might as well give them rituximab.
Yeah, if they're already hypogam, I think it's not
Their B cells are already broken, so just get rid of them. And that's what I do in patients with 22q deletion, actually. In patients with 22q, I use rituximab very early, and they respond really well, but they do usually need to be redosed when the B cells recover, so they end up hypogam. But 22q deletion patients end up hypogam most of the time anyway. So if they're in that autoimmune immune dysregulation cohort of 22q, so
Thank you.
yeah.
Thank you for your presentations. I'm Cindy Martinez from Bogotá, Colombia. I have a question. What is your recommendation for second-line treatment in patients with difficult for access to el thrombopag?
So just to understand the question, is it difficult to take the medication? Is there?
No. It's difficult
Just can't
to
get it.
access to
Can't get it.
Yeah.
Can't take it.
If you can take it, I've done various strategies. I think the big thing with L-Trombopag is the diet interaction and needing to take on an empty stomach, and you're not supposed to break up the pill, but anecdotally, in a small child who can't swallow the medicine, breaking it up does have some impact, if that's your question, but I'm looking like it's not
My
your question.
It's difficult to access for the system. No,
You
no.
can't get the
Okay.
medicine. You can't get it for your patient.
I don't know the intricacies of like compassionate drug company access in your country, but that would be my typical approach if you have some connection.
I think outside the U.S., a lot of times patients have to go to azathioprine or dapsone or other drugs like that because outside the U.S. and Canada and some countries in Europe, I think sometimes access is restricted. And so to the TPORAs, I think it is worth asking about reaching out to manufacturers for compassionate use, especially if it's a one-off patient. But for a larger patient population, it might be harder. Sometimes you can get partnerships too with other investigators and other things like that in order to be able to try to get access to drug.
So we now have in green the $1 million question. So why does splenectomy not work for everyone? Who wants to take a stab at it?
Because it's not ITP.
I think, yeah, we've defined ITP as this homogeneous set of criteria, but there's probably a lot of non-classic ITP involved in our former diagnosis of ITP. So, immune dysregulation plays a role in some patients. So we can't provide the same treatment to every patient because they're not the same.
Yeah. And I'm going to combine, there's two questions up here, and I'm going to combine them because they're kind of on the same topic. One is about when would you recommend weaning a TPO and how, and the other is sort of this notion of sustained response off treatment.
So I think there's a bit of a variation in terms of how to wean a TPO-RA from people that just more quickly stop and those that try weaning. Me, myself, I prefer the weaning technique. And I look at markers like immature platelet fraction on therapy. And as that begins to drop, then I usually drop. But I also look at total platelet count and symptoms. And I think from funding perspective, I always get asked on renewal forms, if I've attempted to wean. So I at least try once per year.
Yeah. Well, I usually do when I have a platelet count that's in the normal range with a decrease in platelet turnover. So if the IPF is dropping, I'll try to wean if the platelet count's normal, and then get to the minimal dose. But usually if you're at the point where your IPF is normalizing, you can get them off.
Yeah. And I think it's looking at the two in combination to get an idea of what your kinetics are while on the TPO, to be reassured that you're not still in a state of high turnover where weaning is going to start to cause problems. And I think it's nice to, as Living said, to periodically come back to it.
Yeah.
I mean, just because you do it once and it doesn't work doesn't mean that the disease is now not in a different state at a later time. The notion of sustained response off treatment, I think, is really now being explored in some prospective adult studies where I think we'll get much better information from that study. The data that we do have right now is also taking only those patients who responded up front. So the numbers that we see, we already started with a population that didn't even respond in the first place. So when you see numbers like 30% it's not 30% of all treated patients, right? So I think, and I think we're still trying to tease out. There was a little discussion maybe today during one of the platelet sessions about trying to understand why this phenomenon is happening in terms of what is the antigen that we're increasing that might be leading to this kind of tolerance situation, although tolerance is a difficult word to say without really, when you're not backed by your basic scientists because they want the data. So I think there is more to come on the story of sustained response off treatment. And I think for all these drugs, right? Yeah. Not just the TPO-RAs, but for any oral drug that requires ongoing therapy, any study should really be looking at that because it's really important when we talk to families to be able to tell them what they should expect in terms of duration and coming off and what would that look like. So I think that we need to be encouraging that as an endpoint in clinical trials as well going forward. I wanted to come back. We have one, I'm going to skip the one in green and just skip down for just a second because we haven't spent a lot of time on first-line therapy. And we have a question down at the bottom on the criteria to start a patient on IVIG. And so I thought we'd loop back to our presentation on first-line therapy and just address that question.
Yeah, so for IVIG, I typically would reserve this to a patient with more significant bleeding at presentation. So this is a patient that you're going to want to observe in hospital and is not suitable for going home. So more moderate type bleeding if there's a drop in hemoglobin. Sometimes it's also if there's at my institution, the review of a peripheral blood smear is not very quick. It doesn't come back in hours, like they take their time, and sometimes it's 24 hours, even when you call them. So if there is a bit of diagnostic uncertainty and there's bleeding, maybe they have one or two lymph nodes, which may be post-viral infection, and if there's a bit of uncertainty, I would do IVIG over steroids if you're thinking that this could be a weird leukemia presentation, but those would be my two criteria.
Our next question is about making changes in L-thrombopeg or how we use L-thrombopeg. And this is a completely off-label discussion. So I'm going to just start by saying that what we do in clinical practice oftentimes is what's reasonable to do in clinical practice and not what the label indication says. So again, I think that if it works for your patient, it's worth trying, because we do have this. We have really some difficulties in getting, precision with our dosing. So I have tried alternating or dosing strategies with L-thrombopag, the same way that I don't necessarily dose adjust a platelet count of 30 on Ramiplast, if that's getting me a platelet count that's reasonable for what the child wants to do in terms of activities. So I do think that we probably, I think the charge is to us, again, to bring about some more real-world dosing data, and this is probably something that we could look at, because I'm sure we're all doing it.
Yeah, I mean, I take away days
Yeah,
on L-thrombopag. If you're on
every
L-thrombopag
other.
7 days a week, I go to it depends on if I've tried every other and they failed that. So we might go to 5 days a week or 6 days a week, and they don't take it on the weekends, and then they get to have ice cream all they want on weekends and those sorts of things. So I take away days.
I also find sometimes it's what happens too is I want to dose reduce down, but the family just got a delivery of a huge number of pills that I'm not about to tell them not to continue taking. So we find a strategy with what they have to use up the pills at home, to not also waste what they have in stock.
And I've had trouble getting insurance to agree to pay for 50 and 25 milligram tablets. So alternating days is really hard. So I'll just take away a day or take away 2 days.
And while we're on this topic, we touched on it briefly, but just working around dietary restrictions, any thoughts on how to, give some advice on working with a toddler and dietary restrictions for L-thrombopag?
Typically, most patients are either dosed first thing in the morning on an empty stomach or last thing before bed. And some families have even chosen to wake their child up in the middle of the night and give the medication. I haven't thought of anything better than those two strategies for the diet interaction. But providing people a list of foods that contain calcium and a list of foods that don't contain calcium is important for, even taking that medicine first thing in the morning.
And particularly for the toddlers, the parents can wake the kid up, or not fully wake the baby up before they go to bed. So baby goes to bed at 8, parents go to bed at 11, wake the baby up just a little bit, enough to get them to take the medicine, because they're probably on the powder for oral suspension. So you just squirt that in their mouth and they go right back to sleep. And then, same thing with Nplate, actually, at night when they're sleeping, so they don't fight you.
And then again, with L-thrombopag use in kind of congenital thrombocytopenias, there are studies open, there are registries open using these drugs in other settings. The congenital thrombocytopenias is one of them. Chemotherapy-induced thrombocytopenia is another. So again, they are being used, and there's no hard and fast contraindication, but there are registries trying to get the data on this. And then there was a question about vaccines that flipped off, but I think to our core, at least I as a pediatrician always encourage vaccination. Getting something by not being vaccinated is often far worse and more detrimental to a patient than the vaccine. And we just monitor platelet counts around that time and mostly tell the family to watch for bleeding symptoms, actually. So then I think we'll end on the bright note, which is how many patients have you observed with remission without treatment? And I'm assuming this is for ITP. And I think the bright note is that it does happen. It happens quite frequently, particularly in the pediatric population. We don't need to feel inclined up front to treat in order to get that child to demonstrate a remission of their ITP. And that's the bright spot for us. That's what makes our job at least a little bit easier maybe than the adults. And then, when we encounter the patient that doesn't get better on their own, then that's when all of this thought process comes in. But I think the bright spot is to know that we don't have to feel inclined to treat somebody to get that remission. And we know this from studies like the Tiki trial that showed us that IVIG or placebo was really no different in that endpoint. So I think we can end there with the bright picture, which is that the majority of children are going to do well. And this talk was really focused on that small group that we all see and we all struggle with every day, and that there's really new things coming down the pipeline to help these patients as well. So thank you again for your time and attention this afternoon. You can complete your CME evaluation credits by scanning the QR code again. The other QR code on the screen will take attendees. This is a downloadable slide deck as well. So the previous slide was CME. This is the slide deck and educational resources. And you can pass questions, you can pass everything off to staff if you need to as well. So thank you. They're in the back. They just did the jazz hands. So if you look for them, they can collect your CME as well. So thank you again for your participation, really engaging.